Welcome to Medical Logistics 101 Stroke Overview. Stroke Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Stroke definition: a sudden loss of blood flow to the brain. Two main types: ischemic strokes, blocked vessel, usually resulting from a clot originating elsewhere, such as the carotid arteries in the neck or the heart in the case of atrial fibrillation. Hemorrhagic strokes, where there's actual vessel rupture, example, aneurysm rupture, less common than ischemic. And I would include a third category that's not a true stroke, but it produces stroke symptoms, and that would be a TIA, transient ischemic attack. Stroke symptoms, but they're transient, and patients get better with time. Time is brain. Minutes count. Brain tissue is extremely sensitive to a lack of oxygen. Treatment is time dependent, not symptom dependent. You never wait to see if the symptoms resolve. Last known well time is a very important piece of information to know. If the patient wakes up with the symptoms and they only know that they went to bed at a certain time, that would be their last known well time. Goal for door to needle time, you got to get them to the appropriate setting, get a CT scan as rapidly as possible. And generally, if they're going by EMS, the patient should generally go directly to CT. The CT scan's primary role is to rule out a brain bleed, and that will guide treatment. Red flags, fast plus. Fast, face drooping, arm weakness or numbness, speech difficulty, time to call 911. Plus findings: sudden vision loss, sudden severe imbalance, sudden confusion or trouble understanding, sudden severe headache. Often that's associated with subarachnoid hemorrhage. Sudden inability to walk normally. Examples that I've seen: families may say they were fine at breakfast and suddenly they couldn't get their words out. They reached for something and their arm didn't work. They keep leaning to one side and didn't realize it. Why you should call 911. EMS calls stroke alert to the hospital, saves precious time. Stroke team activation early. Usually, as I said, direct the CT when the EMS arrives if there's a suspicion for stroke. Driving yourself or having someone drive you delays care and risks safety if your condition worsens en route. EMS can identify stroke mimics and stabilize the patient en route. Initial rapid evaluation, straight to CT if the patient is stable. That's the advantage of EMS. Neurologist, for a lot of facilities, and especially smaller rural hospitals, that's usually going to be a teleneurologist. This is someone that's going to actually examine the patient through a camera in the room. So the neurologist will often be alerted even before the CT result is known, even before the patient even leaves CT to go to their exam room. Obviously, a very quick exam, IV established, PLC glucose, labs, EKG. CT of the brain and a CTA. CTA just stands for CT angiogram. This is looking at the vessels in the neck, looking for large vessel occlusions. Main thing we need to know with the CT of the brain: is this a hemorrhagic stroke or an ischemic stroke? Is it a stroke mimic, seizure, hypoglycemia? Does the patient have a history of migraines? Is there infection present? Any of these could produce some stroke symptoms. Ischemic stroke, thrombolytic medications, so-called clot buster medications, sometimes given if the patient is within the treatment window and they don't have contraindications to receiving the thrombolytic medications. Critical question: when was the last known well time? Because this is a time-dependent treatment. You got to review contraindications of the thrombolytic medications to make sure the patient is a candidate. Possible endovascular interventions, transfer. I would say that sometimes with large vessel occlusions that the patient may need to be transferred to a facility that has endovascular capability. That's not going to be a lot of small hospitals, and even medium-sized hospitals may not have that capability. Treatments: hemorrhagic stroke, brain bleed. Typically emphasize blood pressure control because oftentimes their blood pressure will be very elevated. They'll have a history of hypertension, frequently maybe untreated hypertension. Reversal of blood thinners if applicable. Neurosurgery in select cases, again, that's going to be a transfer to a facility that has that capability. Stroke mimics, seizures, hypoglycemia. That's why we always check a POC, point of care glucose, at the bedside when they arrive. Migraines can have stroke symptoms. Certainly we never attribute that to the migraine. We're going to rule out a true stroke in those patients. Infections, medication effects, absolutely can produce slurred speech, other symptoms, changes in their gait. Bell's palsy, a common viral illness that can produce some minor stroke symptoms that patients may be concerned about, and certainly they should be evaluated. They don't always require a head CT. Intoxication clearly could produce altered gait, altered speech, Pitfalls: waiting to see if the symptoms resolve, assuming it's just fatigue or stress, driving to the hospital instead of calling 911. Important point: not knowing the last known well time, not realizing symptoms can be subtle, example, speech or vision changes. Always been a challenge. Sometimes patients' speech was already somewhat slurred, so you have to rely upon family. How does their speech seem compared to what it was yesterday? Vision changes, this can be subtle as well. Visual field defects, and that's something that has to be carefully evaluated at the bedside. Thinking strokes only happen to the elderly. I've certainly seen young people with strokes. Confusion of mimics with stroke, example, migraines. Stroke aftermath. Strokes are highly variable in presentation. Rehab is often essential. Emotional cognitive changes after a stroke are common. Recovery is a marathon, not a sprint. Uh, just very variable in presentation. Some people, the symptoms can be minor, and I always told patients that had very minor deficits after a stroke, I said, look, you don't think of it this way, but it can be a blessing that you maybe will reduce these risk factors and never have the major stroke that would have left you severely disabled. Stroke prevention, obviously, these are well known. Blood pressure control, which oftentimes there are people with a history of hypertension, maybe on one or more medications, but still not have good blood pressure control. Diabetes control, again, they may have a diagnosis of diabetes, but either not managing it well, it's just not well controlled. Clearly stop smoking, known risk factor for multiple diseases. Treat atrial fib, patient may be unaware they're even in atrial fib. Manage your cholesterol, very hard to do sometimes for some patients, particularly with poor dietary habits. Regular exercise, critically important for a variety of reasons. Know your family history. If you're a high risk candidate, you certainly need to be taking extra steps to prevent that first stroke. Closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss.